So I farm so hard the employees wanna find me, and then wanna hire me. What's 100K to a guy like me? Could you please remind me? Farm so hard, this ain't easy. Working late nights, you best believe me. My grades can only go ace. Never wanna see another B unless I'm Jay-Z. Farm so hard, let's get paid.
Hey guys, Jimmy Pruitt here, and read a study today that really had me thinking, because it comes up quite often in my ED, and I'm pretty sure it comes up pretty often in your ED as well. And the question that really came up had me rethinking anticoagulation reversal in mild brain bleeds. There's new studies out there, there's new challenges, but again, most of the guidelines are all on board with, no matter what's going on, reversing those patients. Because again, those guidelines didn't have any studies that says that you shouldn't. But I found something today that was pretty intriguing. It was an article published in Pharmacotherapy in March of last year, and the title was actually phenomenal. Is reversal of anticoagulation necessary in neurologically intact traumatic intracranial hemorrhage? And this was authored by Kelly Powell, William Curtis, Aaron Sadiq, and Jason Heck. Sorry if I said the name wrong. So this study explored the necessity of anticoagulation reversal in patients, specifically those that were traumatic in nature, that had an intracranial hemorrhage. This was a retrospective cohort study. It was 35 centers between 2018 and 2021. And of course, as we mentioned before, all traumatic ICH. And as far as the details of it, it was about 650 patients with minor traumatic intracranial hemorrhage on anticoagulation. They looked at patients that had a GCS score of 15 and an abbreviated injury scale had a score of 2 to 4, really just making sure that those patients were not severely injured. And the comparison was between 260 patients that had anticoagulation reversed compared to 391 that did not. And it excluded all patients that require emergent neurological procedures or with a pre-injury P2Y12 inhibitor. And what they found was very unique, because it's the first study that really looked at this in its nature. When you're looking at a comparison of in-hospital mortality or hospice rates between those patients who had anticoagulation, there was no difference at 4.6 compared to 4.9. And of course, this was not statistically significant. And this was really unique because not only was mortality is always a challenging thing to look at, but hospice rates, I think, was a phenomenal outcome to combine to really capture the things that people really care about. And there was also no difference in other outcomes as well, such as ICU length of stay, with them staying only about a day in both, and hospital complications in those patients, again, 8% in both. So there's no major difference between those two groups. So what does all of this mean? It really makes us have to consider that some patients with minor ICH may not necessarily require a reversal, and there may be reduced risks that we can avoid. Again, those patients are on anticoagulation for a reason, and this also could be cost saving in nature for the healthcare system and the patient. We can't get too deep into this. This was only one study, and it was well done. And hats off to the authors for conducting this, but it was observational in nature. There are potential confounding factors that may not have been accounted for. And we have to be very realistic about what their patient population and patient selection was. And when we're talking about this, applying these to these patients that, again, had very little deficits at all. And those patients have less chance of hematoma expansion. But again, that is such a unpredictable marker for us to look at. And this is going to require clinical judgment with individual patient factors being guided with this. So for the future, we have to really understand all of this and put this in context that current guidelines still say reversal of ICH in pretty much all cases for the most part, with a few of the guidelines saying you can have individualized care. But I think about this from a medical legal standpoint. Most of my neurosurgeons, they probably won't care. If the patients had a DOAC or if they have an INR that is above 2, they're going to want to reverse. But this is where it comes into a consideration for a lot of pharmacists, is whether or not, if those patients have been beyond 12 hours of DOAC use, and those patients potentially could do a little better overall and have bleeds, and they have no other issues, it may be a conversation that needs to happen amongst the ICU, the ED, and neurosurgery. But as I mentioned before, hematoma expansion is unpredictable within those first few days. And there may be patients that come in, look absolutely great, and you as a healthcare professional can make the recommendation. And if it doesn't go right, we have to start thinking about all of the issues that go with that as well, since it's such an unpredictable nature. And ultimately, this is a first of, I hope, many studies that analyze this. So not just we can have one study on this, but multiple to help identify exactly what those patients look like. Because I think as we practice more, we have to get to a point where there's not a black and white answer, and it's more of it depends, and more data will help us identify what the it depends look like. So that's something that's going to be really unique as we move forward, and something for all of us to look at. And this just opens the door potentially for safe, more cost-effective ICH care. But we have to stay involved and really dig deeper. And I'm hoping that many people do more research similar to this in a way that is going to be ethical and appropriate. So lots of questions come from this. Do you reverse all patients despite severity? Is there variety in practice? Is this evidence-based? This is the first study that really looked at this question in great detail. But how does this align with the latest data? Or maybe newer studies coming out now that we just haven't looked at, that's been recently published and not have been seen since all of the information that comes out in 2025. And patient-centered, how do individual factors actually impact these decisions? So these are all phenomenal questions that I have for all of you. And I look forward to diving deeper into this. And I think this will be a very unique thing that we look at as we move forward.
Closes it. Ozzy scratches his head. Whatever she's looking for, it isn't in there.
Perfect.